So by definition, it is a collection of symptoms which is brought about by abnormal compression of the neurovascular bundle by bony, ligamentous or muscular structures in a narrow space between the clavicle and the first rib. So this is the thoracic outlet syndrome definition. So what are the levels of compression? So there are 3 levels of compression. So as you go along on the upper side, this is the first level of compression. This is called as an interscalene triangle. This is the first level. So it is bound by the anterior scalene muscle, the middle scalene muscle, and down you have the first rib. The structures which go through this interscalene triangle are obviously seen in this diagram are the subclavian artery, vein, and the brachial plexus. Second area of compression is the costoclavicular space. So this comes below the clavicle. So as the brachial plexus and the neurovascular bundle passes through below the clavicle, it forms the second area of compression. So mostly it is bound by the subclavius muscle here. And in this area, the main compressing feature, I mean the organ which is compressed mainly is the subclavian vein. However, there can be nerve compressions also in this area. Third space which is compressed is the below the pectoralis minor muscle. So finally, the brachial plexus and the neurovascular bundle pass below the pectoralis minor muscle, and it forms the another third triangle. So this is the subpectoral minor space. This is an anatomical dissection or cadaveric dissection which shows the which shows the subcostal space and the subpectoral space. Structures at risk in this type of in a thoracic outlet syndrome are the brachial plexus, mainly the lower plexus C8T1, subclavian artery, and the subclavian vein. We classify a thoracic outlet syndrome into 2 types, mainly the vascular, which is very uncommon, and the neurogenic, which is very common. A vascular syndrome is distinguished into another 2 types, is the arterial and the venous type. And a neurogenic is also classified into 2 types, is a true neurogenic type, which is normally electrophysiologically positive. Like you'll get some findings on the EMG NCV, and the non-specific type. That is, there are no findings on the EMG NCV. So the non-specific type is the most commonest, and 95% people have a non-specific type of thoracic outlet syndrome. Here is the problem with the diagnosis, because most of them have non-specific thoracic outlet syndrome. So as I said, neurogenic type accounts for 90% and vascular 3 to 4%. So the causes for thoracic outlet syndrome of anything which intervenes or compresses the structures in these 3 triangles can cause a thoracic outlet syndrome. First and the most common is the cervical rib. Then there can be a long C7 transverse process, anomalous insertion of the scalenus muscle, a scalenus muscle hypertrophy. There can be a scalenus minimus muscle, abnormal bands or ligaments, a fractured clavicle which throws a lot of callus, or a first rib which can throw a lot of callus, can also compress this area, and exostosis and tumors in these areas. So there can be variation in the scalenus muscle which causes compression, the cervical ribs, and anomalous first rib. So cervical rib is a extra rib which arises normally from the 7th cervical vertebra, and rarely it arises from the 6th or 5th cervical vertebra. Remember, in most of the patients, most of the subjects, there is a cervical rib from childhood, and it is very common in bilateral. Bilaterally, they have a cervical rib. However, only 10 to 15% of the patients are symptomatic with bilateral cervical rib. So not all patients having cervical rib will be called as a thoracic outlet syndrome. So you will have to do some tests to find out that it is a cervical outlet, it is a thoracic outlet syndrome, or any other compression neuropathy, like we know it can be a ulnar compression in the cubital tunnel, or the Guyon's canal, or a median nerve compression anywhere along. So these are the types of cervical rib we normally see in the clinical scenario on X-rays and on CT scans. It can be bony, completely bony. It can be fibrous and bony, or it can be completely fibrous, or only there can be a bony swelling in the end. So normally for noting the cervical rib, finding the cervical rib, we take a normal PA X-ray of the chest. However, lordotic views are very important, which shows the apex of the lungs and the cervical ribs clearly, as seen in this picture. So, what are the symptoms of thoracic outlet syndrome? So, as most common is the neuritic type, a neurogenic type. So, neuritic pain most commonly along the C8 T1 is the like along the ulnar nerve area. So patient will complain or intractable pain or radiating pain or sensory loss along the ulnar nerve area. There can be interosseous muscle atrophy. There can be headaches, trapezial pains, muscle weakness. There can be atrophy of the muscles. There can be some vasomotor signs due to ganglion problems, or there can be a hypersensitivity and CRPS. Venous compression are mostly due to in the subcostal region. There can be acute occlusion due to a thrombus which is lodged in the vein. This can be a syndromic problem mainly. So there can be pain, tightness, and discomfort during surgery. So in a chronic scenario, it can be an increased venous pattern or tenderness in an axillary vein area, and gangrene is very rare. Arterial problems, arterial compressions are also very commoner than the venous problems. There can be a digital ischemia, hand ischemia, cutaneous ulceration, forearm pain, and a bruit or a pulsatile mass can be seen in the supraclavicular area. So difficult problem is the diagnosis. So how will you diagnose a thoracic outlet syndrome? The most important thing to diagnose a thoracic outlet syndrome are the provocative clinical maneuvers. So even if you do hundreds of investigations, those are your backup. But the provocative clinical maneuvers are the most important thing to diagnose a thoracic outlet syndrome. The other investigations which you can do are the radiography, ultrasound, and MR can be done. A CT is done, CT angio is done, angiography is done, and a venography is also done. So this is written by David Roose. The most accurate diagnosis of the thoracic outlet syndrome must rely on a careful history and thorough appropriate physical examination. And that is it. That is the crux of this talk. Like, physical examination is very important in a thoracic outlet syndrome. No single diagnostics test is sufficient to specifically prove or exclude the diagnosis of thoracic outlet syndrome. It is a diagnosis of exclusion. So after you have ruled out your carpal tunnels, your ulnar pains, your other problems in the peripheral nerves, everything you rule out, you don't label the patient as a psychiatric patient or the patient with factitious disorders. You have to find out if the final thing, the thoracic outlet syndrome, is in play, because most of the clinicians, they will label the patient as a factitious disorder. And then one note, the person who has examined him on the first day, the diagnosis continues to remain with him for life, and the patient continues to have pain for life. So always rule out other compression neuropathies. In a physical examination, always look for the distal pulse, compare it with the opposite side, edema, cyanosis, any veins or dilated veins in the supraclavicular area, tenderness over the scalenus or the pectoralis minor muscle, as in trigger points, reduce sensation to very light touch on fingers, and the provocative maneuver. So what is a provocative maneuver? The provocative test is a test. It should be reproduced. Any test which should be reproduced is a provocative test. So in thoracic outlet syndrome, normally the radial pulses get diminished or obliterated. So there have been multiple provocative maneuvers in the history, and it has been described. We are not going to go into the details of all the provocative maneuvers. So as in literature, this is what Greens have given. Adson's Wright and Halstead test. Halstead is the person who has described thoracic outlet syndrome in the beginning of 1800s. So these all older tests they frequently come positive in normal population. They are neither sensitive nor specific. So we in our literature or in our post-graduation days, we always learn this test, how to do this test. But the single most important test, which is important and has a very high sensitivity, is the Roose test. So this is the Roose test. Normally what you do, this is also called as external, this is all, the arm is held in external rotation and for elbow in 90 degrees, and the patient is asked to do this maneuver of flexion and extension of the palm of like gripping and leaving the grip very vigorously for 3 minutes. So you always look for the reproduction of the symptoms, fatigue, pain, or any nerve symptoms. As you can see in this patient, this is given by Dr. Pankaj Ahire. You can see this side is looking vascular, like it is pink. However, after doing the maneuver for some time, you can see this hand is become pale. So this is a classical Roose test. So you have to do this test, and this is the only test which I recommend instead of doing other all manuals. You can do other manuals, you can do physical examination, but Roose test is the single most important test which has to be done. So how do you interpret the Roose test? In a neurogenic thoracic outlet syndrome, there can be heaviness, progressive weakness, numbness, tingling in the fingers, and progression in of the symptoms on arm up. Venous has a cyanotic arm with distended forearm veins, and arterial thoracic outlet syndrome can show ischemia and cramping pain. After you get this test positive, go for lordotic views, find out if there is a cervical rib or any other problem in the X-ray. Do a PA view as well as a lordotic view. However, the drawbacks of the X-rays are that you cannot see soft tissue anomalies. Hence, you have to go ahead with the other tests. So there are specialized imaging in a thoracic outlet syndrome. Angiography is the gold standard for thoracic outlet syndrome. However, angiography is only mainly for arterial type of compression. Hence, we have to get a duplex sonography, a venography, and always do a positional maneuver during all these studies. Consider bilateral studies. So this is a test angiography, a CT angiogram basically, which is showing that there is no compression in when the patient is in normal adducted position. However, as soon as you extend and abduct the arm, you can see there is a compression in the subclavian area. So this is a classical CT angio picture in a thoracic outlet arterial syndrome. This is a static thoracic static CT angiogram, which is showing compression at the first rib area, and there is a distension of the subclavian artery distal to that. So this is also this patient also had a severe pain in his arm, but this was it didn't need any provocative maneuvers. The patient just had pain. So a CT angio showed this thing very vividly. Electrodiagnostic evaluation like the EMG, NCV, typically with neurogenic type of thoracic outlet syndrome, it can have a normal, as I said, electrodiagnostic study. However, it is important to do this test to rule out other compression neuropathies like the carpal tunnel or the cubital tunnel syndromes. Treatment is the most important thing is to treat it conservatively in the beginning. So if the patient has mild symptoms, numbness, and pain on Roose test, try to treat it conservatively. So you have to modify the posture and correct the faulty posture, manipulate and mobilize and relax the first rib, clavicular and other muscles, strengthen the shoulder girdle muscles, and you can stretch the scalenus muscle. Pain control medications can be given, ultrasound by a physiotherapist, TENS can be given, and local anesthetic injections have also been tried. So what are the indications of surgeries? Failure of supervised exercise and postural program for more than 3 months or more is an indication for surgery. Then intractable pain in the first visit itself is an indication for surgery. Significant neurological deficit which is progressing when the patient has presented to you, and if there is an impeding vascular catastrophe, usually of an arterial origin, is an indication for surgery. So these are the specific indications for surgery in a thoracic outlet syndrome. What do I remember during surgery of thoracic outlet syndrome? Take a detailed consent of possible complication, because it is a very critical area which a surgeon is going to enter. So always take a detailed consent. However trained the surgeon is, there can be complications. So detailed consent is always necessary. Assistant for me could be a vascular surgeon or a trained hand and upper limb surgeon and a brachial plexus surgeon. I would always like to have an assistant with me or a senior mentor with me who has taught me during his course for this surgery, because it is a very critical surgery and you don't want, because single small mistake can injure critical structures there. So approaches are supraclavicular approach, which is a preferred approach by most of the surgeons, and a transaxillary approach. Supraclavicular approach is mostly used for a cervical rib excision, and transaxillary approach is used by surgeons for recurrent thoracic outlet syndrome and for the excision of the first rib. So this is a supraclavicular approach. These pictures are given to my mentor, Dr. Raja Savapati and Dr. Hari from Ganga Hospital. So as you take the supraclavicular incision and retract the platysma and the sternocleidomastoid, you go and enter on the scalenus muscle. You can see a phrenic nerve always crosses the scalenus anticus muscle, and you can see the brachial plexus roots there and there. Retract and you divide the scalenus anticus muscle. You see what you see down is a subclavian artery and the brachial plexus. Here the subclavian artery can be seen very clearly. And as soon as you retract, this subclavian artery has as a transverse cervical artery here. You can ligate it if the subclavian artery is not moving. Retract the subclavian artery medially, and you can see the cervical rib down there, and the cervical rib can be excised. So to conclude, diagnosis is mainly clinical. Roose test is most important. Neurogenic and non-specific neurogenic type is most common. Non-specific electrodiagnostically negative are most common type of thoracic outlet syndrome. Dynamic CT angio may help in diagnosis. Supraclavicular approach is good for scalenectomy and cervical rib excision. Transaxillary approach is used for first rib excision and in case of recurrence.